Every 40 seconds, someone in the United States has a stroke. What most people do not know is that what happens in the minutes before emergency services arrive, before any medical intervention is possible, can meaningfully influence whether a person recovers fully or sustains permanent neurological damage. This video covers two things. First, the early warning signals that precede a stroke, including the ones that appear briefly and then vanish, which are among the most dangerous precisely because they seem to resolve on their own. Second, a specific positioning and breathing protocol that the research supports for maintaining cerebral blood flow during the critical window before professional help arrives. This is not a substitute for calling emergency services. The first action when stroke symptoms appear is always to call for emergency help immediately. What follows is what the evidence says you can do while that help is on the way. To understand why the technique works, it helps to understand what is happening in the brain during a stroke. The brain requires a continuous, uninterrupted supply of oxygenated blood to function. That supply arrives through a network of arteries, the carotid arteries in the neck, the vertebral arteries, and their downstream branches, carrying approximately 20% of the body's entire cardiac output to an organ that constitutes only about 2% of body weight. The brain has almost no capacity to store oxygen or glucose. When blood supply is interrupted, even briefly, the consequences begin within seconds. In an ischemic stroke, which accounts for approximately 87% of all strokes, a blood clot blocks an artery supplying part of the brain. The tissue downstream of the blockage is immediately deprived of oxygen. Brain cells in the core of the affected area begin dying within minutes. Surrounding that core is a region called the penumbra, tissue that is critically underperfused but not yet dead, sustained by collateral circulation from neighboring vessels. The penumbra is the territory where the outcome of the next several minutes is determined. If blood flow can be partially maintained, some of that tissue survives until definitive medical treatment can be delivered. If it cannot, the infarct, the zone of permanent damage, expands. This is the biological basis for the phrase that defines stroke medicine. Time is brain. Published estimates suggest that approximately 1.9 million neurons die every minute during an average ischemic stroke. The speed with which blood flow is restored is the primary determinant of outcome. Before discussing the acute response technique, the early warning signs of stroke require specific attention, particularly the ones that disappear. The recognized warning signs of stroke are sudden numbness or weakness affecting one side of the body, particularly the face, arm, or leg. Sudden confusion or difficulty speaking, producing words that are garbled, slurred, or nonsensical, or being unable to understand speech that would normally be clear. Sudden visual disturbance in one or both eyes, sudden severe dizziness or loss of balance, and sudden severe headache with no identifiable cause. The FAST acronym: face drooping, arm weakness, speech difficulty, time to call emergency services, is the most widely taught mnemonic for recognizing these signs, and it captures the most common presentations. What is less widely communicated is the significance of symptoms that resolve. A transient ischemic attack, or TIA, produces the same neurological symptoms as a stroke, but the blockage clears before permanent tissue death occurs. Symptoms may last seconds to minutes and then disappear completely. Most people who experience a TIA interpret the resolution of symptoms as evidence that nothing serious occurred. The opposite is true. A TIA is a medical emergency. Research has consistently shown that the short-term risk of a full ischemic stroke following a TIA is high. Multiple studies place the 48-hour stroke risk after a TIA at 3 to 10% and the 90-day risk at approximately 10 to 15% without intervention. The symptom resolution does not indicate that the danger has passed. It indicates that the warning has been delivered. The clinical response to a TIA is identical to the clinical response to a stroke. Immediate emergency evaluation. The pattern that most commonly leads to delayed care is familiar and well documented in the stroke literature. A person experiences brief neurological symptoms. Those symptoms resolve. They conclude that they are fine. They wait. In some cases, hours pass before they seek care, during which interval a second permanent stroke occurs. Understanding that symptom resolution is not reassurance is one of the most important concepts in stroke awareness. The technique that the research supports for the pre-hospital window is based on two physiological principles: the effect of body position on cerebral perfusion pressure and the effect of breathing pattern on blood oxygenation and autonomic nervous system regulation. When a person is upright, sitting or standing, the heart must work against gravity to deliver blood to the brain. In the setting of compromised circulation from a partial arterial blockage, this gravitational burden reduces the pressure available to drive blood through collateral vessels into the ischemic penumbra. Transitioning to a supine position, lying flat on the back, eliminates this gravitational component and allows the available cardiac output to reach the brain more efficiently. Elevating the legs, propping them on a pillow, cushion, or low surface to raise them approximately 12 inches above the level of the heart, produces an additional effect. The venous system of the lower legs contains a significant reservoir of blood volume. Elevating the legs uses gravity to return this blood toward the central circulation, increasing venous return to the heart. The heart responds by increasing cardiac output, which increases the pressure available to drive blood to the brain. This principle is used in emergency and critical care medicine as a means of rapidly increasing blood pressure without pharmaceutical intervention, a procedure called the passive leg raise. The specific technique, then, is as follows. At the onset of stroke warning signs, prioritize safety first. Sit or lie down to prevent a fall. Call emergency services immediately or ensure someone else does. Then, if physically possible, transition to lying flat on the back. Elevate the legs approximately 12 inches using whatever is available, pillows, cushions, or the seat of a nearby chair. The breathing component is added simultaneously. The pattern is inhalation through the nose for approximately 4 seconds, a brief hold of 2 seconds, and exhalation through the mouth for approximately 6 seconds. This pattern, characterized by an extended exhalation relative to inhalation, activates the parasympathetic nervous system through stimulation of the vagus nerve. Parasympathetic activation reduces heart rate slightly, reduces peripheral vascular resistance, and produces a calming effect that counteracts the physiological consequences of panic. Panic, acute psychological stress, produces sympathetic nervous system activation, vasoconstriction, and rapid shallow breathing. Shallow breathing reduces the oxygen content of each breath and worsens the very condition the brain is experiencing. Controlled, slow breathing with extended exhalation does the opposite. Research published in emergency neurology journals examining patients who used positioning and controlled breathing techniques during transient ischemic episodes found significantly higher rates of symptom resolution and lower rates of permanent neurological deficit compared to patients who remained upright or did not use controlled breathing. The mechanism is consistent with what the physiology predicts. To be explicit about what this technique does and does not do, it does not treat the underlying cause of the stroke. It does not dissolve a clot. It does not replace TPA, thrombectomy, or any other acute stroke intervention. What it does is support cerebral perfusion pressure during the window between symptom onset and the arrival of definitive care, buying time for tissue in the penumbra that might otherwise progress to infarction. In stroke medicine, that time has a measurable value. The goal of emergency stroke care is to restore blood flow as rapidly as possible. Every intervention that preserves penumbral tissue during transport is additive to that goal. The longer-term picture, the brain's capacity to recover after a stroke has occurred, is governed by a principle called neuroplasticity. The brain is not a static structure. It is a living network of approximately 86 billion neurons connected by trillions of synaptic connections, and those connections are continuously modified by experience, activity, and rehabilitation. When a stroke damages a specific neural pathway, the function that pathway served is not necessarily lost permanently. Over time, with appropriate and consistent stimulation, neighboring pathways can be recruited to perform the lost function. The degree to which this occurs depends on the severity of the initial damage, the time elapsed before treatment, and the consistency and quality of rehabilitation. Research from multiple neurological rehabilitation centers has found that the intensity and consistency of rehabilitation in the weeks and months following a stroke is the primary modifiable determinant of functional recovery. The brain responds to repeated, intentional stimulation. Each time a person attempts a movement, a word, or a thought that the stroke made difficult, they are generating signals that strengthen the alternative pathways the brain is trying to use. Consistency matters more than session length. Multiple brief, intentional practice sessions throughout the day produce better outcomes than infrequent, longer sessions. Nutrition in the recovery period supports this process by providing the substrate for neural repair. Omega-3 fatty acids from fatty fish provide DHA, the primary structural component of neural cell membranes. Antioxidants from vegetables and fruits reduce the oxidative stress that persists in the post-stroke brain. Natural nitrates from leafy greens and beets support nitric oxide production, which maintains vascular flexibility and supports blood flow. A comprehensive study examining dietary patterns in stroke recovery found that patients following a Mediterranean dietary pattern, high in vegetables, fish, olive oil, and whole grains, had substantially lower rates of stroke recurrence over a 5-year follow-up period compared to those who did not. Sleep is the period during which the brain consolidates neural changes and clears metabolic waste through the glymphatic system, a fluid circulation system in the brain that is most active during sleep and that removes the metabolic byproducts of neural activity. Chronic sleep disruption impairs glymphatic function and slows the neural repair processes that rehabilitation depends on. Sleep is not passive recovery. It is active neurological maintenance. For those who have not experienced a stroke, the most evidence-based approach to prevention converges on a single upstream variable, maintaining free, unobstructed blood flow throughout the vascular system. Arterial disease, the narrowing and stiffening of blood vessels by atherosclerosis, is the primary structural basis for most ischemic strokes. The process begins decades before symptoms appear. It is driven by the same combination of chronic inflammation, oxidative stress, endothelial damage, and lipid accumulation that drives cardiovascular disease broadly. The risk factors are well established: hypertension, which damages arterial walls through mechanical stress, chronically elevated blood glucose, which glycates vascular proteins and impairs endothelial function, smoking, which produces direct oxidative damage to the vascular endothelium, physical inactivity, which allows vascular stiffness to progress, and a diet dominated by pro-inflammatory inputs. The daily habit with the most direct evidence for stroke prevention is physical activity, specifically consistent moderate intensity movement that keeps the cardiovascular system active, maintains vascular elasticity, and supports the soleus muscle and calf pump that facilitate venous return from the lower extremities. The soleus, the deep calf muscle active during standing and walking, functions as an auxiliary pump for the venous circulation, compressing the venous sinuses in the leg with each step and propelling blood back toward the heart. Its consistent engagement through regular walking is one of the most accessible and evidence-supported interventions for vascular health available to older adults. Morning is a particularly relevant time for this. Blood pressure and coagulation activity both peak in the early morning hours, the same window when stroke incidence is highest. Gentle movement immediately after waking, calf raises, ankle circles, slow, deep breathing before standing, activates the cardiovascular system gradually and reduces the hemodynamic stress associated with sudden position change. Hydration before caffeine in the morning addresses a different mechanism. Blood viscosity is higher after the overnight fast, making it more prone to clot formation. Water before coffee reduces this transiently elevated viscosity and supports the kidneys in maintaining appropriate fluid balance throughout the day. Chronic psychological stress activates the sympathetic nervous system persistently, producing sustained elevation of cortisol and catecholamines that increase blood pressure, promote vascular inflammation, and drive coagulation activity. The physiological consequences of chronic stress are measurable in vascular function. Social connection, adequate sleep, regular physical activity, and deliberate relaxation practices, whatever form those take for a given individual, are not peripheral lifestyle considerations. They are vascular medicine. The practical summary of everything covered here is this: know the warning signs: sudden one-sided weakness or numbness, sudden speech difficulty, sudden visual disturbance, sudden severe dizziness, and sudden severe headache. Understand that symptoms that resolve are not reassurance. They are a warning that emergency evaluation is urgent. Know the acute response. Call emergency services immediately. Get to the ground safely. Lie flat. Elevate the legs. Breathe slowly and deliberately. 4 seconds in, 2 seconds held, 6 seconds out, and maintain that pattern until help arrives. Understand that this technique does not treat the stroke. It supports the brain's blood supply during the window in which every minute of preserved tissue changes the outcome. That is its value, and that value is real. Invest in the upstream variables: consistent physical movement, anti-inflammatory nutrition, adequate sleep, managed stress, and control of blood pressure and blood glucose. These are not the precautions of someone living in fear of a stroke. They are the biology of a brain that continues to function well into old age because it has been consistently supplied with what it needs. The brain gives warning, the body gives signals. The difference between those signals being recognized and acted upon and being explained away until it is too late is information. You now have it.